For the last segment of my discussion, I want to go over some of our supporting clinical data. We've looked at many patients. We've treated thousands of patients over nearly a 2-decade period. We recently reported on the use of a defined plant-based diet. I want to emphasize, a defined plant-based diet because it utilizes our food prescription approach, and it's not just a simple, say, vegan or not vegan or whatever, but it gives you definition in terms of how the food's prepared and so on, because it helps out in terms of the precision and reproducibility of the diet. So what we found is that in the clinical setting, we can effectively treat hyperlipidemia, hypertension, and reduce medications at the same time. We had about 31 patients, mostly female. We had mostly ethnic African Americans. Mean BMI was high, but the entry criteria was hypertension and hyperlipidemia. We did not actively recruit diabetics, but a fair number of them were diabetics, and of course, most were overweight and the like. About a third of them had a diagnosis of coronary artery disease, 27% with diabetes, and 23% arthritic conditions. Here's a food classification system. I'm not going to go through the details with you, but in essence, level 0 is raw liquefied food. So it'd be something that's cold pressed juice or a smoothie or the like. Water also classifies as food level 0. 1 through 3 are raw solid foods. 1 is low glycemic index, 3 is high glycemic index, and 2 is in the middle. 4 is the transition zone. 4A are raw foods that are high fat content. So it's greater than 20% fat per caloric intake of that food. These would be like your seeds, avocados, or the like would be 4A. 4B are dehydrated foods, less than or equal to 160 degrees. We plan to modify this to probably less than or equal to 140 degrees, maybe 120 degrees in our future publication of this. And 4C is when you start to add modest amounts of heat in the form of blanching. Then 5 is boiling, steaming for prolonged periods of time, and 6, boiling and steaming for even longer. We don't advocate microwaving of the food. That throws it beyond 6. Frying and high temperature grilling, especially with oil, this throws the food into 7. So you can be on a plant-based diet, but if you prepare the food in the wrong way, it gets outside the range of what we recommend in the food classification system. And so that's why I like using the numbering system, because many people come in and say, well, I'm eating a whole food plant-based diet. And I say, well, how are you preparing the food? Well, I'm a sauteing and a microwaving or whatever the case is. And when we change these food preparation techniques, we see drastic improvements in terms of what they do or how well they do. This gives an outline of what the patients ate. And at baseline, you see large increases in the amount of the plant foods they consume. Of note here, the avocado consumption went up by 9-fold, 800%, and they still got pretty significant improvement in overall condition, as I'll show you later. And there's certain foods that went down because they were on a raw diet. The amount of grains they consumed went down because many grains are cooked. The potatoes and all that. So they went down because they were on a raw diet, not because we only reduced those. Nuts and seeds did go up by 17%. Overall, the percent fat in that diet was about 20%. So it was about a 20% fat diet. So what did we see on a biochemical standpoint? First of all, total cholesterol, LDL cholesterol went down. So did HDL cholesterol. That typically happens on a plant-based diet that we see. The triglycerides also went down. Notice the glucose level did not go down significantly. Now that's important. So the fasting glucose level from baseline to end did not go down significantly. But what did happen is that we saw about a 3.4% reduction in hemoglobin A1C. That was statistically significant. Now, there are 2 things I want to point out. Well, 3 more than the 2 things. 1, fasting glucose did not go down. So put a pin there. 2, we did not screen, or excuse me, we did not actively recruit diabetic patients. And 3, hemoglobin A1C represents generally the average glucose over 3 months. So how do you see a significant drop in this in 1 month when it's average over 3 months? Well, what I can say is that the other factor that contributes to hemoglobin A1C is fluctuations in blood sugar. So when you see a rapid fluctuation in blood sugar, that will also influence the hemoglobin A1C level. And oftentimes when doctors are following patient hemoglobin A1C, they may be ramping up on the insulins or oral hyperglycemic agents based on the hemoglobin A1C going up. But the fasting blood sugars are not going up. It's just that the blood sugar swings are high. And what I think is happening here, we don't measure for this, but my theory is that we reduce the blood sugar swings and therefore reduce the hemoglobin A1C. And you can make that argument easily because number one, A1C measures average blood sugar over 3 months. Even if it only measured over 1 month, we didn't see a change in average fasting blood sugar over 1 month. So there must be something else that's changing here. And the only other thing I know is blood sugar fluctuations. So I think what's happening is on the defined plant-based diet, you're seeing a reduction in postprandial blood sugar levels, and therefore you're seeing a reduction in hemoglobin A1C, and you can see that it's FACC1. And we've been seeing this for over 2 decades. This is not the first time we've shown this data. We've seen it. Other data is not published, but this is published data, and we've seen this for a long time. Excuse me. C-reactive protein went down by 30%. We've been seeing this for nearly 2 decades, 30% or more. Reduction is pretty consistent with reduction in just 1 week. Systolic and diastolic blood pressure levels were reduced. Total cholesterol, LDL cholesterol levels were reduced. And of course, the medications. So at baseline, they were taking an average of 2.6 medication, went down to 1.6 medications, while at the same time, blood pressure was going down. We also saw significant reduction in antihypertensive medications in the same group. We also saw a reduction in inflammatory markers. So lipoprotein(a), we were the first in the medical literature to show reduction in lipoprotein(a) with nutrition. And we also saw reduction in inflammation. Here you see LP(a), of course, total cholesterol was reduced in a very short period of time. ApoB, ApoA1. Really what I want to show you here, of course, you saw weight reduction by just 6%. And notice that C-reactive protein and other biochemical markers, the lipids and the like, LDL cholesterol, all these are reduced by double digit, while weight's only reduced by single digit. So although we look at weight, we measure weight, the biochemistry is changing at a much faster rate and much more extensively than your weight reduction is. As some of the inflammatory markers, 30% reduction in C-reactive protein. Cytokines, IL-6 reduced by 23%, plaque-2 reduced by 16%, and total white blood count was reduced by 22%. Now notice white count started within normal range. Normal white counts around about 3.5 to about 10. But we saw a reduction from 6.3 to 4.8. That was a significant change. What does that mean? That means that these white counts that were normal are probably high normal, or probably they're statistically normal, but they're probably not biologically normal. Biologically normal white counts are probably somewhere in the order of 3 to 4, 3 to 5, not so much 3 to 10. May even be 2.5 to 5. But statistically normal white counts, because so many people are walking around with oxidative stress and inflammation, you get your blood count checked, the white count 7 or 8, and your doctor says, oh, it's normal. It probably isn't normal. Normal might be 2 or 3. In this case, we saw a significant drop with a significant clinical improvement in these patients. So I want to end there. What I wanted to do is give you an overview of our overall approach clinically and show how the impact of an aggressive nutritional regimen, what it can have on the patient, even in the acute setting. The most acute setting, from the point of cardiac arrest to the point of acute illness in patients with long-standing chronic illness. But this regimen, this approach can be used in the acute setting and should be used in the acute setting because it improves the overall outcomes. Recently, I was managing a patient with heart failure. And so she admitted her, and this was within the last few weeks, admitted her to the hospital because she had severe mitral regurgitation and her heart was beating around 20, 30%. And so we were going to give her a mitral valve clip. My colleague was going to do the clipping or repair the mitral valve. saw her in the ICU and said, look, she's too far gone, let her go. Another colleague, I wanted to implant a biventricular pacemaker defibrillator sort of help cardiac output. She saw, no, she's too far gone. So we had on a Milanone drip. What I did, the patient was crying. I said, look, settle down. This is what we're going to do. I put on a nutritional detox. She was on food level 0, smoothies with algae. I started on coenzyme Q10 and vitamin C in the liposomal format. And so we detoxed her in a 1-week period of time in the hospital, weaned her off the Milanone. She was discharged from hospice, went to a nursing home, and essentially left the nursing home after about a day and a half, went home. I saw her back in the office a week after that. She was dancing, happy, smiling, and she's still undergoing the detox process and medication adjustment. But this shows you the acute effects of a nutritional intervention in patients who are acutely ill and how important it can have on the overall outcome. Thank you very much for your attention. And